So now the fun part begins. So we will go ahead and review all the diseases that can present with chest pain. So here is a table of all the diseases that can present with chest pain, and we will compare and contrast these different diseases and come up with high yield questions and some really key distinguishing features. So there will be a lot of compare and contrast here in the next few slides. There is going to be some repetition, so I'm sorry about that, but please bear with me. Hopefully this will be of value to you. So first we'll compare and contrast cardiac ischemia and aortic stenosis, or HOCM, or hypertrophic obstructive cardiomyopathy. So we know that both of these disease categories have really very similar features. So therefore, what should we do? Well, if we have a patient who comes in with chest pain and we are looking at some risk factors, the first good question to ask would be, after reviewing vital signs, we must ask about duration. So that's the time course. And then OPQRST questions are extremely important. So when you ask about it and the answers to these questions become something like this: the pain was gradual and it got better with rest and worse with exertion. And then their patients may use a lot of different vocabulary when you ask about quality or characteristic of pain, and patient may say that, oh, it's a pressure, or it's a tightness, or some people say it's a knot. Some people even put a fist on their chest and don't even call it pain. But anyhow, there are all kinds of different ways people describe it, plus more. So keep that in mind. And then if they say that the pain is radiating to the left arm, then it becomes a very positive finding for cardiac ischemia. But if they say that it's radiating to the jaw, then it becomes very classic of aortic stenosis. And then these people usually have moderate pain, so they don't necessarily say that this is the worst pain they've ever had. So it's not necessarily very severe. So whenever you see answers to OPQRST questions like this, then of course we should start thinking about either cardiac ischemia or aortic stenosis or HOCM in the presence of risk factors. Therefore, these questions become very important. So keep in mind to definitely ask these and look for these answers. And then how do we contrast? Well, the risk factors for cardiac ischemia will be, you already know all of these risk factors, so I just review it here. The only difference would be in the presentation of pain, that angina patients usually they don't have pain from minutes to hours, they have longer duration pain. So what happens is they say that they've been having pain for quite some time, and it's very predictable and it gets better with rest. So they self-limit their activities, and therefore they just have episodic pain with very predictable amount of exertion. So that is going to be a little bit different. But MI and unstable angina patients are going to almost always say that pain started a few minutes to a few hours ago. It's not like several days or several weeks. Patients with aortic stenosis present very similar to angina, so they have very predictable chest pain, and it looks very much like this, except that it radiates to the jaw. And then what else do we see? We also see that they have shortness of breath and possibly syncope. So whenever you have chest pain, shortness of breath, and syncope on any exam question or in any patient, then definitely rule out aortic stenosis. Another, of course, distinguishing feature would be physical exam. So when you move on to do physical exam, then you can see that the patient with aortic stenosis and HOCM has a murmur. The only difference between these two would be, of course, the quality of murmur and physical exam findings and age. So patients with aortic stenosis are usually older, and HOCM patients are younger. And you can see aortic stenosis risk factors are very similar to the cardiac ischemia risk factors, except for it's not as many. And then also they may have a history of bicuspid aortic valve or a family history of aortic stenosis, and HOCM patients may have a family history of HOCM. So that's how we compare and contrast. So therefore, you can see that the big questions or the good questions would be OPQRST questions and questions about risk factors whenever you're suspecting these things. Next is so another two diseases that look very similar or have at least some commonality as far as chest pain is concerned. So how do we compare and contrast those two? So patients with aortic dissection usually have pretty severe pain. It's persistent pain. It radiates to the back. It starts within a few minutes, and patients present very quickly, usually not more than a few hours. and their risk factors would be history of uncontrolled hypertension, possibly Marfan, and possibly syphilis. So those two, like I said, are not as common, but definitely if they have any of these risk factors present, definitely think about aortic dissection if the pain is radiating to the back. And very quickly they develop hypotension, so of course looking at vitals will be important. Therefore whenever you see any hypertensive patient whose pain is radiating to the back, this would be something to not miss at all. These people usually are older, but if they have a family history of Marfan's, they may be young as well. Then you have pneumothorax contrasting with aortic dissection. So this pain will also be very severe, very sharp, and it usually starts very suddenly, just like aortic dissection, but the pain starts to get better with time and dyspnea continues. So that is the difference. Another difference is that these people are usually younger, and they also may have a history of smoking, but smoking can be present anywhere. So you can see smoking does not separate the two. It actually doesn't separate anybody from anything, but it adds to the probability of a disease if it is present. So you can see the big differences would be the characteristic of pain being persistent and radiating to the back, and then sharp and getting a little bit better, and then presence of shortness of breath, which will be actually present in both of them. Pneumothorax patients don't nearly have as many risk factors. Then we have musculoskeletal chest pain. So this is the most common cause of chest pain in general population, but if you add risk factors, then it is not as common as some of the other things. So the key feature would be a reproducibility of pain. So of course that should be a good question to ask from the patient. And this pain again will be localized to one side. It is exacerbated by change in position, so not necessarily exertion, but change in position. So they may be just laying down in bed and moving from one position to another, and that's when they have more pain. So that is something important to keep in mind. And they may have a recent history of overuse or trauma, and in severe cases they may just have fractured a rib. The important thing to keep in mind is that we should think about this in the absence of red flags. So for example, these people should not have any hypertension or hemodynamic instability. They should not have all the characteristic findings of chest pain consistent with acute coronary syndrome and stuff like that. So that is very important to recognize. So therefore those questions, although even if you are highly suspecting that this is musculoskeletal pain, those questions will be important to ask. And then again, like I said, it's very common, but then definitely look for red flags as well. So here is a table showing gastrointestinal causes of chest pain. So I'm going just in the order of being more common to less common. So this again is a very common cause of chest pain, GERD being the most common. So of course these people usually have postprandial or post-emesis pain. And again, GERD pain is going to be center of the chest, more like burning, and it starts after several minutes after they eat. So not right after they eat. And diffuse esophageal spasm is usually very few seconds or several seconds after they've eaten, and sometimes in severe cases they have dysphagia. And people with people who have recently vomited or they had hematemesis, they have esophageal tear, so that's what you should suspect. So therefore when you are considering these diagnoses in anybody who has chest pain, a good question to ask would be if this is postprandial or post-emesis, and if they say yes, then you can go further down the road and ask more specific detailed questions. But you don't want to necessarily ask do you have hematemesis as your first question when somebody comes in with chest pain. So go down this path only if they have any of the more obvious things present, or more high yield more high yield finding present. Next is comparing and contrasting between these four things. So you have endocarditis, myocarditis, pneumonia, and lung abscess. So of course the key common feature among all these four would be fever. So they have fever and have any of this present, and at least two of them have productive cough, then definitely think about these things. So more specifically, what do you have? So again, if your patient comes in and you're asking after you've asked the good questions about chest pain and other things that we just talked about, another very good question would be fever. So if they have fever, then you go down the list and ask further questions. So you say, okay, Do you have fever with chills? And then if there is any prosthetic valve, if there is any history of IV drug use, or there is any hardware in the body. So if patient says positive to some of these things, or if you know from history that there is something positive, then definitely think about endocarditis. On the other hand, if the fever is low grade and it's indolent, and very quickly they start developing cardiac decompensation, and there was some preceding viral illness, then you think about myocarditis. So therefore, after you've asked about fever and asked a few questions and they were not necessarily positive, you might want to ask if they had any upper respiratory infection in the last few weeks, and that's how you will link it to myocarditis. Again, if they have fever with cough, then these two things become very possible, so very likely. So but the cough has to be productive cough, or well, it doesn't have to be, but usually it is going to be productive cough. So we know that a dry cough is going to be present in other situations too, so we just ask about phlegm, and if they do have high grade fever, chills and phlegm, then maybe pneumonia is very likely. And if they did not respond to antibiotic treatment, or if they are immunocompromised, or they are drinking alcohol very massively, or for whatever reason they are at risk for aspiration, then you definitely think about lung abscess. So that's how you can increase your probability for these two diagnoses if these features are present. Again, I suggest that you ask about fever first, and if they do have it present, then you start asking about cough and all these other detailed questions. But then to add complexity to it, so in medicine nothing is black and white, so your very young and very old patients don't necessarily have this classic presentation with pneumonia. So keep that in mind. But at this level, at your level, before clinicals, this information is just good enough. All right, so the next is these three things that are also quite common causes of chest pain, and there is something similar. There is a key common finding between all these three things. So can you tell what is the key feature that is going to be common in these three things? Let's see. If you can tell, then kudos to you. Well, this is going to be pleuritic chest pain. So pleuritic chest pain is something that's positive in all these three things. So pericarditis, pulmonary embolism, and pleuritic chest pain or pleurisy. All those three present very similar. So when you are asking your patient about chest pain questions, one very good question obviously would be if their pain is worse with inspiration or deep inspiration. So if they say yes, then you can go ahead and start thinking about these three diagnoses, and then you ask further more detailed, more specific questions about these three. So there is going to be some distinction among these three things, and how do we discern that? So we know that pericarditis patients will say that, or you will notice that in their history, they either had a recent MI, or maybe they have an autoimmune disorder, for example, rheumatoid arthritis or lupus. Oh, and on physical exam, they have a pericardial friction rub, and you already listened to the rub, so that's how they will present. So if these things are present, then you think, okay, it is pericarditis maybe. Patients with PE will be very much more sudden and dramatic presentation. So they have not only pleuritic chest pain, along with that they may have some shortness of breath. They usually have a precedence, so they have HIV things, which is basically hypercoagulability, immobility, and venous stasis. So if they have any of the risk factors, and I'm not going to go into the detail in the risk factors here, we already discussed it many times. So if they have any of those present, then you think, okay, maybe it is PE. So therefore, when you have pleuritic chest pain and and you're thinking about these three diagnoses, then definitely your set of questions should be around those risk factors. And if the patient has those present, then definitely rule out PE with your labs and tests. If the patient had a recent lung infection, so the patient just had pneumonia a few days or weeks ago, or they have any autoimmune disorder also, then we will think about pleurisy. And then pleural rub is going to be present on the physical exam. This will become a little bit more easy to diagnose if it's on the right side, because the left-sided pleurisy and left-sided pericarditis will look quite similar to each other. The only difference, the pericarditis is going to be much more sick. And then sometimes people have pleuropericarditis, so figure that out. So they have, of course, exactly the same presentation, except that now they have the pleura on top of pericardium. They're both involved, so basically it's inflammation of everything in there, so people will be more sick. Another important thing to keep in mind is that patients with pericarditis, they can develop, pericarditis can develop as a result of recent MI or autoimmune disorder, but also there are some very important risk factors. For example, chemotherapy can cause pleural effusion, radiation therapy can cause pleural effusion and therefore cardiac tamponade. So if you go back in history and you know the patient received radiation treatment for whatever reason, maybe they had Hodgkin lymphoma or any cancer and they got radiation treatment for it, then if they are presenting with shortness of breath, and it doesn't have to be chest pain, because once the pleural effusion gets large they don't have chest pain anymore, then you should definitely think about effusion or tamponade. All right, so the next is lung cancer. So this gray thing here, so this is another possible cause of chest pain, although people with lung cancer usually have other very strong or obvious chief complaints, so chest pain may not be their main chief complaint, but it can be that. So whenever you are asking about chest pain and it's been longer duration, so usually they don't present within a few hours or even days, they take a while before they come in and see you. So if the duration of chest pain has been long, then you will suspect, okay, maybe it is chest pain of longer duration. So you will say, okay, maybe this patient has weight loss and cough. So you ask about cough or chronic cough, and maybe it is hemoptysis, and if you ask about weight loss and if they have lost weight, then definitely you will raise the probability of lung cancer. In addition to that, and their pain will be usually dull and chronic, and they also have possibly productive or non-productive cough, but they also can present with extrapulmonary findings. For example, extraneoplastic findings of lung cancer. For example, they may have SIADH, so they basically present with those symptoms, which is basically dizziness and confusion and all that. They may have some other extraneoplastic manifestations. For example, they may come in with Horner syndrome or so some paralysis. So those are just more complicated situations or scenarios, so you are probably not going to see it very much, especially at this level. Just keep in mind chronic cough, possibly with hemoptysis and weight loss, and if they have chest pain, then definitely lung cancer should be a diagnosis to consider. Now if they have a history of smoking, then this becomes extremely possible, an older age. So remember that older age group, history of smoking and all these things. Now if there is no smoking history, the distinguishing feature between lung cancer and tuberculosis would be that in TB people have a history of travel. So that is the history of travel versus history of smoking is the key distinguishing feature between lung cancer and TB. Also with TB, people usually don't have chest pain, but cough is the common finding. But then some people travel and smoke, so figure that out. And so of course, then you will suspect both things, and then you will just figure out based upon your physical exam and lab findings what the patient has, and chest x-ray will be of course helpful. Next is shingles. So people will come in with chest pain, possibly if they have shingles, and this will be of course only if the pain is in the dermatomal distribution where you have the chest. So people usually have a vesicle, so therefore it is a good idea to do physical exam. That's how you will know that this is shingles. Usually the pain is not very unique or characteristic of anything special, so you may not be able to get an idea that this is shingles until you look at the patient. That is something to keep in mind. And usually they have preherpetic and postherpetic pain, and it's burning and tingling, and usually these are going to be your older patients or immunocompromised patients who are at risk for developing shingles. And the last thing is anxiety. So anxiety is also possible. So these people have palpitations, shortness of breath, numbness and tingling. So And you can see these are very multi-system symptoms. So that's one thing to keep in mind when people come in and right at the answer they say, I got chest pain, I can't breathe, I got numbness and tingling in my feet and hands. And so they have multitude of symptoms and they have no risk factors. Then you can definitely think about anxiety. Again, it's a diagnosis of exclusion, and if it is episodic and there is episodes of hypertension and tachycardia along with it, then definitely think about pheochromocytoma. So this is just you already know about this, we went over this. So this is the prototypical case. All right, so this is the probably the best slide in this, or the most fun slide of the whole presentation. So here's your putting everything together. So you have cardiac ischemia patients come in with this, aortic dissection patients, sudden tearing chest pain, endocarditis, and then you have myocarditis, both with fever, pericarditis with pleuritic chest pain, aortic stenosis with syncope and shortness of breath, and then pneumothorax and PE. Pneumothorax with pleuritic pain and PE with sharp pain. Then you have pneumonia and other fever. Then you have pleurisy with pleuritic pain. You have weight loss, lung abscess with fever, and then you have reproducible pain, and then you have postprandial pains, and then you have shingles, vesicles, and then you have anxiety. So anyway, the point is putting it all together and looking at the commonalities. So you see that you have sudden tearing chest pain or sharp pain in the setting of pneumo and the aortic dissection. You have chest pain with risk factors and possibly shortness of breath, with or without syncope, aortic stenosis, and cardiac ischemia. Then you have fever in 4 different things present with risk factors and of course further symptoms. And then you have weight loss, that's one category of its own. Then you have reproducible pain and postprandial pain, and then you have these last 2 categories. So therefore it makes sense to whenever you're evaluating somebody with chest pain, first ask about the pain itself and then think about all those diseases. And of course there are many, but this is not something to be intimidated with. What you do is you start with your vital signs, you look at that, make sure the patient is hemodynamically stable. If not, then definitely think about dissection or complications of cardiac ischemia, for example left ventricular wall rupture or something like severe MR, so anything like that. And so if you're hemodynamically if the patient is hemodynamically not stable, then you, of course you will start intervening right away. If they are stable, then you can of course continue to take history. And a good set of questions would be your OPQ-RST questions about the pain itself, and from that you can get a lot of clue and you can hone in your diagnosis on a few of these. And then after that, of course, to make sure that you remove your anchor bias and make sure you weigh all the probabilities properly, a good question to ask would be about shortness of breath, because you can see that's present in many things. Another good question would be about cough and fever. So fever is present. If it is present, then you think about these 4 things. If the pain, when you're asking about pain and it was indeed pleuritic chest pain, then of course you ask about these 3 different things, or think about these 3 different things, or ask more detailed and specific questions. If you asked about postprandial nature of the pain, then of course you think about this. If you asked about weight loss, then definitely think about lung cancer. So anyhow, these things, these questions become your high yield questions. So it is a good idea that ask at least these questions, and based upon this you can get pretty close to the diagnosis. You can see there is a fair amount of overlap in all these diseases, but then again, once you have done a thorough job of asking questions, chances are you will be very close to the diagnosis before even you start your physical exam. And then with physical exam, oftentimes you can get a lot of more helpful information if you did a good exam. But remember that history is still the key, because if you're not thinking about a specific diagnosis, you're probably not going to look for those physical exam findings in the patient either. So for example, if you're not thinking about endocarditis, you're probably not going to look for those microemboli findings like Roth spots and Osler nodes and those things in the patient. If you're not if you're not thinking about lung abscess, you're probably not gonna look for those findings on physical exam, on chest auscultation. So all those things become all these diagnoses to begin with, you should keep in mind. Therefore, prior knowledge is extremely important. The only additional thing I'll say would be that there are acute causes of pain and chronic causes of chest pain. Most of these chest pains are going to be actually acute, but some, if the patient says the pain has been going on for a long time, then possibly angina. Also, aortic stenosis patients will look very similar to angina patients. Then your patients with lung cancer will probably say that this has been going on for a while. Lung abscess may be for a while, but then usually they have, a pneumonia that preceded it. Musculoskeletal pain can go on for quite a few days and even weeks, and then GERD can also go on for a long time. Shingles usually lasts a few days or several weeks, and then anxiety is usually long duration, but it's very episodic, so it comes on for a few. So at that time when the patient has pain, that particular episode will be just a few seconds or minutes, but usually they have a longer history as such. The rest all are going to be your acute chest pains, so that's something to keep in mind. So therefore, when you ask about duration, you can very easily go down the route of more acute pains versus chronic pains. And if the patient says pain has been quite some time, then it makes it very easy for you to do further evaluation, because you know that very few diagnoses are likely now. So there's just a review. This is the final slide. So this is my mind map of chest pain, and again, this is not to intimidate or anything, but this is just putting everything together. So what we do is, we have chest pain, we ask these questions about OPQRST, and then based upon that, if the patient has very classic OPQRST findings, or the answers to these questions are very consistent with ischemia, then of course we will go this route and we'll say, okay, let me do the EKG and draw cardiac enzymes if the patient has cardiovascular risk factors present too. And then of course in this case you are thinking about acute coronary syndrome. If the patient has any of these present along with some shortness of breath and syncope, and there is a murmur too, then obviously you're going to do echo because you're thinking about aortic stenosis. If the patient has very tearing chest pain and it's radiating to the back, then you're going to think, and there is some hemodynamic instability, then definitely think about dissection and do CT scan. If there is sharp pain and there are anxiety symptoms, then maybe it is anxiety. If there is pain along with shortness of breath also, then definitely this goes to dissection also possibly. And then if there is shortness of breath with pleuritic chest pain, and you can see here pleuritic chest pain, and they have any risk factors, the HIV or VIH risk factors, and they have positive HOMAN, then definitely do a CT scan of the chest. D-dimer will only help a little bit, but then also pleuritic chest pain should also make you think about where is it? Okay, so pleuritic chest pain will also make you think about pleurisy and pericarditis. If the patient has, along with the chest pain, some preceding illness and there is dullness on the exam, then maybe there is some pneumonia. Or just because of just with the presence of preceding illness, you may think about effusion. If there are vesicles present, then of course you think about shingles. If there is reproducibility of chest pain, then you think about musculoskeletal chest pain. I'm sorry, this should have been actually pleural effusion or pericarditis, so I made a mistake here, so I apologize. If the pain is accompanied by a cough and fever, then of course you think about pneumonia. There may be some shortness of breath. If there is cough and fever and maybe shortness of breath, but now also have weight loss, then definitely think about cancer. Of course their exam findings will be abnormal, and if they have any of these things present, then you should do a chest x-ray and a CT scan or a sputum to make sure there is no tuberculosis, especially if there is weight loss. If it is very postprandial, then obviously, and it's relieved by antacids, then definitely think about GERD or some of the other gastrointestinal causes of chest pain. So this is just a mind map showing how you can approach it, or how you can link all the diagnoses. with different symptoms and signs, and how you can mentally organize your thoughts. So you can organize your information or your knowledge any way you want. It can be a simple paragraph or anything, but it's a good idea to organize it, because you don't want to just leave all your prior knowledge in a scattered fashion. It will be very difficult for you to evaluate a patient if you don't have some organization. So this finishes our discussion on chest pain. I'm sorry that it was too long, but I hope it was valuable, and I hope it brought some things to clarity, and when you are actually seeing a patient, it will be very easy for you to do that. Thank you so much. Have a great day.